viewers, welcome to Medikine 24/7. Today we will be discussing the topic shock. Please watch the video till the end and follow us on Instagram at Medikine 24/7 for more exciting medical contents.
In this video, we'll be discussing about the classification, etiology, and the stages of the development of shock and correlated pathogenetic mechanisms. So what is shock? Shock is a pathologic condition due to widespread failure of tissue perfusion, which is characterized by acute circulatory failure, decreased effective circulatory volume, and inadequate microcirculatory perfusion in tissues and organs. In the previous slide, we mentioned something called effective circulatory volume. So what is ECV? ECV is the volume of blood circulating in the cardiovascular system in a particular time, and it is basically the speed with which the blood passes through the vasculature of the body. At a point of time, the amount of ECV depends upon the blood volume present in the body, the cardiac output by the heart, and the vascular capacity of the body, which further depends upon the vasoconstriction and vasodilation. Classification of shock can be done in many ways. According to the initial alteration in the body caused by the shock, it can be divided into hypovolemic shock, which is brought about by total decreased blood volume in the body, vasogenic shock, also known as distributive shock, which is caused by alterations in the microvasculature, that is either excessive vasoconstriction or excessive vasodilation. It can be subdivided into anaphylactic shock, neurogenic shock, and septic shock. And lastly, cardiogenic shock, which is brought about by improper cardiac function, that is decreased cardiac output, which fails to maintain tissue perfusion. According to the hemodynamics of shock, it can be divided into hyperdynamic shock and hypodynamic shock. Hyperdynamic shock is characterized by total decrease in TPR, or total peripheral resistance, and there is an increase in total blood flow. There is also increased cardiac output. This is why it's also known as warm shock, because whenever there is increased blood flow in the peripheral tissue beds, there is increase in temperature. In hypodynamic shock, the thing is totally opposite. There is total increase in TPR, or total peripheral resistance. There is total decrease in blood flow and decreased cardiac output. There is less blood flowing in the tissue beds, which leads to fall in body temperature. That's why it's also known as cold shock. According to the causes or etiology, shock can be divided into hemorrhagic shock, which leads to hypovolemia, dehydration shock, which also leads to hypovolemia, shock caused by burn, which leads to a combination of many effects like hypovolemia and improper cardiac function, traumatic shock, and obstructive shock. Now let's look at the different types of shock and their etiology. We haven't focused on every shock here, but we have focused on the important ones and the important causes often leading to shock. In case of cardiogenic shock, it is primarily caused by myocardial infarction, cardiomyopathy, which can be hypertrophic cardiomyopathy or dilated cardiomyopathy, valvular heart disease, ventricular rupture, congenital heart defects, and papillary muscle rupture. All of the following conditions leads to improper functionality of the cardiac myocytes, and it further leads to decreased cardiac output or decreased ejection fraction, subsequently leading to shock. Obstructive shock can be caused by pulmonary embolism, cardiac tamponade, tension pneumothorax, and dissecting aortic aneurysm. Pulmonary embolism blocks the pulmonary artery or the smaller branches of the pulmonary artery, leading to an acute respiratory distress, which often leads to shock due to improper tissue perfusion and inadequate oxygen supply to the tissue beds. Cardiac tamponade is caused by increased accumulation of fluid in the pericardial space or interpericardial space, which leads to increased pressure on the ventricles, leading to a further form of cardiac failure called restrictive cardiac failure, which further leads to improper tissue perfusion. Tension pneumothorax is caused by presence of air inside the mediastinum or inside the pleura, which further causes pressure on the mediastinal organs and shifting of the mediastinal organs. The heart is affected primarily by tension pneumothorax, and there is improper cardiac functionality. Dissectic aortic aneurysm is another condition where there is separation of the different layers of the aorta, and in the separated layers, blood starts to flow from the aorta into the separated layer of the aortic wall. Hypovolemic shock can be brought about by acute hemorrhage, which leads to increased blood loss and subsequent hypovolemia. Dehydration from vomiting and diarrhea. Overuse of diuretics, burns, and pancreatitis. All of this function leads to some kind of fluid loss from some kind of pathways in the body. Whenever there is fluid loss and that loss isn't compensated by increased fluid and electrolyte intake, there will be a consequence of hypovolemia. And increased hypovolemia leads to shock. Distributive shock is caused by anaphylaxis, neurotrauma to the spinal cord mainly, spinal anesthesia, and sepsis. Microcirculation plays an important role in the pathogenesis of shock. So let us have a brief look at the basic physiology of microcirculation. The microcirculation is basically consists of an arterial side, a venous side, and a capillary in between. The capillary bed in between the arterial and venous side consists of true capillaries, which are also known as nutrition channels, thoroughfare channels, and arteriovenous shunts. In this image, we can see a basic diagram of the tissue capillary bed. True capillaries are those which are present in the middle and which are extensively branched. They have very thin walls, and the velocity of the blood is very slow in the true capillaries. The primary function is to exchange nutrition and return many metabolites to the vessels from the tissue. So this is why they are also known as nutrition channels. Thoroughfare channels are the one which are located more peripherally of the capillary bed and not so extensively branched. The function of these channels are to provide oxygen to the tissues more rapidly. So that's why the thoroughfare channels are more common in skeletal muscles. Arteriovenous shunts are the ones which causes bypass of blood from the arterial side to the venous side. It bypasses the true capillary in between. It bypasses the nutrition and oxygen exchange to some extent, and thereby it reduces the time of the blood needed to flow through the capillary bed. So the opening of the arteriovenous shunts are primarily seen in fever. In the peripheral blood vessels, whenever the arteriovenous shunts are opened in case of fever, there is increased blood flow via the periphery of the tissue capillary beds, which leads to a rise in temperature. In normal physiological condition, the regulation of microcirculation plays a huge role to continue tissue perfusion and to ensure adequate tissue oxygenation, exchange of nutrients, and oxygen supply. The regulation of microcirculation are two-folded mechanism, which is neurohumoral regulation and regulation by local metabolites. Neurohumoral regulation is primarily maintained by the sympathetic nervous system, which releases catecholamines from the adrenal medulla, and catecholamines binds to the alpha adrenoreceptors on the arteriole, which leads to vasoconstriction. The regulation by metabolites are primarily brought about by lactic acid, adenosine, histamine, kinin, hydrogen, potassium ions, and other things, which leads to vasodilation. Well, you may ask that why lactic acid or histamine or is causing vasodilation, but the catecholamines are causing vasoconstriction. Well, whenever there is inadequate oxygen supply, there is signs of hypoxia. The primary sign of hypoxia is local increase in lactic acid because there is a shift from aerobic respiration to anaerobic respiration, which leads to conversion of pyruvic acid to lactic acid in an increased frequency. Increased lactic acid thereby leads to vasodilation, which causes the dilation of the arterial lumens, which leads to increased blood flow, and there is a compensation of the hypoxia. Continuing our discussion from the last slide, if we see that if there is a increased concentration of local metabolites, it leads to relaxation of the vascular smooth muscle cells. Thus, the arteriole and the precapillary sphincters starts to relax, which leads to increased blood flow inside the capillaries. So if there is any local hypoxia, it is primarily compensated by that. Whenever the local metabolites are diluted and transferred out, let's say the compensation is successful and the lactic acid is diluted out because no more new lactic acid is been developing due to proper tissue perfusion, there is increased vascular smooth muscle cell reactivity to vasoactive substances, which are catecholamines secreted by the adrenal medulla, which binds to the alpha adrenoreceptors in the blood vessels. Increased vascular smooth muscle reactivity leads to arteriole and precapillary sphincter closure, and the closure of the sphincter leads to the decreased blood flow. This is the basic regulatory pathway of the microcirculatory perfusion. There are two important points that we have to keep in mind regarding regulation of the microvasculature, that alpha receptors that are present on the arteriolar side are more sensitive to vasoactive substances than those of present in the venular side. Thus, the arteriolar side of the circulation is more sensitive to vasoconstrictive regulation than vasodilating regulation. But the venular side of the circulation is more sensitive to vasodilatory regulation than vasoconstrictory regulation. Low pH sensitivity of the arterioles are also greater than venules. Arterioles can sense less amount of pH in blood much more prominently than venules. Now let's discuss the pathogenesis and stages of shock. There is three primary stages which leads to shock and its pathogenesis, that are ischemic hypoxia stage, also known as initial non-progressive stage of shock, stagnant hypoxia stage, or also known as progressive stage, and microcirculatory failure stage, or irreversible stage. In the first two stages of shock, with adequate compensation and therapeutic support, the shock can be reversed. But if there is microcirculatory failure in the body it is considered as the irreversible phase of the shock. Let's start with ischemic hypoxia stage. The primary microcirculatory changes that are seen in the ischemic hypoxia stage are contraction of arterioles and venules in the microcirculatory bed, closure of true capillaries, and opening of arteriovenous shunts. There is decrease in both inflow and outflow, but as we mentioned before, that the arterial side of the microcirculation is more sensitive to vasoconstrictive influences. So that's why the amount of decrease or the extent of decrease in inflow is much greater than the extent of decrease in outflow. So even if there is overall decrease in both the inflow and outflow, there is always more blood going out of the microcirculatory bed than the amount of blood coming in. In the left hand side of the image, you can see that what is the normal condition of the microcirculatory bed, but the right hand side signifies the ischemic hypoxia stage of shock. Here we can see the opening of the arteriovenous shunts, overall constriction of the arterial and the venular sides of the circulation, and closure of the precapillary sphincters leading to closure of true capillaries. The primary effects of microcirculatory disturbances that are caused are auto blood transfusion. What do we mean by auto blood transfusion is, as we mentioned before, even if there is overall decrease in both inflow and outflow, the outflow is greater than the inflow. So there is increased venous return to the heart. So there is adequate supply to the heart or adequate venous return to the heart, and there is proper preload on the right ventricle. So pulmonary functionality or pulmonary circulation isn't hampered yet. Auto blood infusion is caused by the opening of the arteriovenous shunts and the increased cardiac output and the other compensatory mechanisms. Blood redistribution in systemic circulation is seen and occurs in order to maintain blood circulation in the important organs like brain, kidney, liver, stomach, and etc. Blood redistribution is important because in case of ischemic hypoxia stage, the body cannot afford to lose its vital organs. So that's why it redistributes the systemic circulation from the skin and skeletal muscle towards these organs in order to continue maintaining the blood pressure and adequate tissue oxygenation. The cardiac output increases as we mentioned before, and as a result of the ischemic hypoxia stage and the pathogenetic changes that are or mechanisms that are seen in the ischemic hypoxia stage, there is total increase in the total peripheral resistance, or there is increased TPR. Now let's look at the pathogenetic mechanism of the ischemic hypoxia stage in a flowchart form. All the etiologies of shock leads to some consequences which are decreased blood volume, decreased blood pressure, stress, decreased cardiac output, etc. All of these leads to activation of the sympathetic nervous system, which further causes increased release of the catecholamines. The catecholamines binds to two types of receptors present in different organs: alpha adrenoreceptors and beta adrenoreceptors. Alpha adrenoreceptors are present in skeletal muscles, skin, abdominal muscles, and kidney, whereas beta adrenoreceptors are present in coronary arteries and arteriovenous shunts. The function of both the alpha and beta adrenoreceptors are to cause vasoconstriction. On the other hand, some local mediators like angiotensin II, endothelin, leukotriene 3, thromboxane A2, and antidiuretic hormone increases and causes several changes that are excitation of the senior region of the central nervous system, or increased sweat gland secretion. The vasoconstriction causes the direct consequences of the vasoconstriction is ischemia of the abdominal vessels, ischemia of the skin, increased heart rate, and increased cardiac contractility, which further leads to decreased urine output and decreased anal temperature. Ischemia of the skin leads to pallor or cool limbs or decreased temperature in limbs. And increased heart rate or increased cardiac contractility leads to thready pulse and narrow pulse pressure. Excitation of the superior regions of the CNS leads to agitation and restlessness, and increased sweat gland secretion leads to sweating and clamminess of skin. If the compensation isn't adequate in the ischemic hypoxia stage, the shock progresses to stagnant hypoxia stage. The microcirculatory changes that are seen in this stage are vessels from arterioles to venules begin to dilate. So it's total opposite of the previous stage. In the previous stage, we saw that the vessels starts to constrict, but here the vessel starts to dilate. And as a direct consequence, the true capillary starts to open and there is adhesion and aggregation of blood cells. So as the vessel starts to dilate, there is increased inflow and the outflow decreases. It's not that there is constriction of the outflow tract, but if the inflow tract are opened, the inflow increases than the outflow. The outflow also increases from its normal state, but the overall inflow is greater than the outflow. On the left hand side, we can see the normal condition of the vascular bed, and on the right hand side we can see the condition of the stagnant hypoxia stage, where the arterioles and the venules have dilated and the true capillaries have been opened and there is increased blood flow. We mentioned that there is adhesion and aggregation of blood cells. Why is that? We mentioned before in the basic physiology of microcirculation that the blood velocity in the true capillaries are very slow. And if there is increased dilation of the precapillary sphincters or the arterioles behind it, the blood flow decreases even more. And whenever there is increased decrease in the blood velocity inside the true capillaries, there is stasis of blood, leading to aggregation of several types of blood cells. It can be RBCs, leading to RBC lysis. It can be WBCs. It can be platelets, leading to initiation of the coagulation cascade and formation of local small microvascular clots. Well, this stage also provides as the nidus of formation of DIC or disseminated intravascular coagulation. We have already made a video on disseminated intravascular coagulation. If you want to check it out, you can go to our channel or check out the link in the description. The primary effects of the microcirculatory disturbances are the blood pressure begins to decline and declines further due to decrease in cardiac output, venous return, and peripheral resistance. Well, if you remember the last slide or the last stage, ischemic hypoxia stage, we mentioned that whenever there is vasoconstriction, there is increased outflow than inflow. So there was increased venous return and adequate venous return to the heart, and the heart functioned adequately. But in this case, there is increased vasodilation, and as a direct consequence, the blood pressure decreases. The pressure on the atrial wall decreases. And whenever the blood pressure decreases, there is an automatic compensation by decrease in the cardiac output, and the venous return and the peripheral resistance also decreases. As you can probably guess, by the dilation of the arterial and the venular sides of the microcirculation. Whenever there is dilation, there is lower resistance, and whenever there is constriction, there is higher resistance. The decrease in blood pressure and decreased cardiac output also results in decreased perfusion in heart and brain, and also in the other vital organs. Here is the pathogenetic mechanism of the stagnant hypoxia stage in a flowchart form. We mentioned before that in the stagnant hypoxia stage, the primary consequence or the primary effect is vasodilation of the arterial and venular sides of microcirculation. The vasodilation is brought about by local acidosis, K plus Na plus ATP channel dysfunction, and severe ischemia, acidic metabolite accumulation, and endotoxin accumulation. Local acidosis is caused by inadequate tissue perfusion, where increased lactic acid is generated due to anaerobic respiration, and increased lactate causes decreased response of the vascular smooth muscle cells to vasoactive substances, which leads to vasodilation. Whenever there is inadequate oxygen supply to the tissues, there will be decreased ATP formation, and whenever there is decreased ATP formation, there is improper functionality of the K plus Na plus ATPase pumps, which leads to vasodilation and improper function of the vascular smooth muscle cells. Also, severe ischemia, acidic metabolite accumulation, and endotoxin accumulation leads to secretion of several vasodilative substances, such as nitric oxide, which also leads to vasodilation. We mentioned in the previous slide that there is stasis of blood, or at least there is beginning of stasis of blood, which leads to increased adhesion of WBCs to the blood wall or blood vessel wall. It leads to post-capillary resistance. Post-capillary resistance increase leads to decreased outflow from the venous tracts. Severe ischemia, acidic metabolites accumulation also leads to exosmosis of plasma. Further, it causes aggregation of RBC and platelets and increasing the blood viscosity. Whenever there is increased vasodilation and blood stasis, the hydrostatic pressure on the vascular wall increases. Hence, there is exosmosis of plasma and the blood viscosity increases, exaggerating the aggregation of platelets and RBCs. The increase in post-capillary or venular resistance and vasodilation leads, and also blood viscosity, leads to blood stasis in microcirculation. Blood stasis in microcirculation causes decreased venous return and subsequent decreased cardiac output. Decreased cardiac output causes decreased renal blood flow, which further leads to oliguria or anuria. Decreased blood pressure, which causes improper brain perfusion, leading to several CNS manifestations. And there is stasis in the skin, which leads to cyanosis or maculation of skin. Stasis of blood in the kidney circulation also leads to improper kidney function, where one of the primary consequences of it is oliguria or anuria. Now let's come to the final stage of the development of shock, which is the microcirculatory failure stage, and it's also an irreversible stage of shock where the prognosis of patient are very poor. The primary microcirculatory changes that are seen in this stage are widespread microcirculatory paralysis and dilation, more blood cell adhesion and aggregation, disseminated intravascular coagulation due to increased platelet aggregation, and flow halts inside capillaries. There is neither any inflow or outflow whatsoever. In this state, on the left hand side of the image, we can see a normal functioning microcirculatory bed, and you can compare it to the right hand side, which signifies the microcirculatory failure. We can see increased dilation of the arterioles and the venules, and we can also observe increased formation of intravascular clots and leading to DIC. Sometimes increased shear stress on the thin blood vessels of capillaries due to DIC leads to rupture of the blood vessels, leading to small tiny hemorrhages in the peripheral tissue beds. One characteristic manifestation of this kind of hemorrhage is formation of ecchymosis or punctate hemorrhage. The primary effects of microcirculation disturbances are the obstruction of tissue perfusion, which leads to intravascular congestion. Intravascular congestion further leads to exosmosis of tissue fluids or blood that further exaggerates the stasis of blood. Hypoxia of the hypoxic damage of the vascular smooth muscle cells and the other tissue beds causes release of lysosomal enzymes, further causing serious cell damage, necrosis, and dysfunction of vital organs. Let us see the flowchart form of the microcirculatory failure hypoxia. The pathogenetic mechanism which brings about the effects of the final stage are caused by depressed vasomotor center and damaged vascular smooth muscle cells due to prolonged hypoperfusion. There is increased hypoxic or ischemic damage to the vascular smooth muscle cells. The depressed vasomotor center and the damaged smooth muscle cells leads to failure of the vasoconstrictive responses. Hence, the hypotension is exaggerated and the blood pressure falls even lower. As a direct result, there is weaker heart sounds. Prolonged ischemic hypoxia leads to occlusion of the capillaries due to DIC or disseminated intravascular coagulation. Occlusion of capillaries due to disseminated intravascular coagulation or increased stasis of blood leads to multiple organ dysfunction syndrome or MODS. It's also known as multiple organ failure syndrome or MOFS. It is primarily characterized by anuria, coma, and acute respiratory distress syndrome. The primary manifestation of DIC are subcutaneous ecchymosis and punctate hemorrhage. Thank you for watching our video. Stay tuned for our shock part 2, where we'll be discussing about the cellular and molecular alterations that occurs in shock and the distinct clinical features of different types of shock. If you guys want the PPT of the topics we discuss on our channel or notes of the corresponding topics for free, you only need to subscribe to our YouTube channel and follow on Instagram at medikinate247 and DM us the topic. If you found our video informative and helpful, please like, share and subscribe to our channel for future medical video lectures. Don't forget to press that bell icon. See you on our next video on Medikinate247. Stay healthy, stay safe.